Good evening, everybody, and thank you very much for joining us for our latest webinar from the East Sussex Eye group. It's great to have you all with us. This webinar will be recorded and it will be available to watch on our YouTube channel, the East Sussex Eye group, after this event. There is CET available for those that are watching live, and this CET is available for dispensing opticians and optometrists. This lecture will run for about 45 minutes and with about 15 minutes of questions at the end. So if you have any questions, then at the bottom of your screen, if you scroll down, there is a Q&A box, and if you type in there, and at the end of the lecture, I will then pose the questions to our speaker. So regards our speaker, I'd like to welcome Mr Shahram Kashani. He's an ophthalmic consultant surgeon at East Sussex Care Trust, specialising in the management of complex retinal disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior segment laser treatments, as well as high-volume cataract surgeries. He's previously been the clinical lead for East Sussex NHS Trust and is now the head of retinal services and uveitis. Tonight, he will present to us a lecture on retinal vein occlusions, what you need to know. Normally, I would hand over to Mr. Kashani, but just one question I've got for Mr. Kashani is, I believe it's a special night in your household tonight. So I would like to thank Mr. Kashani because it's somebody's special birthday in his household, and I'd love to know how you've managed to do a webinar tonight.
I hadn't forgotten at all that it was my wife's birthday, and she is very supportive. I might just not be alive by 9 o'clock.
It's really good to hear.
I can't say no to you, Ian. That's what it is.
Well, thank you so much. So the reason for mentioning this now, before we start the lecture, is because obviously I may not be around at the end of the lecture to pose questions to you, because it's a very special friend's birthday and I might be at the pub celebrating. So as you do, or you don't. So, thank you very much, Mr. Kashani. I'll hand over to you now.
Thank you, Ian. Right. Okay, let me see. Share. Ian, can you see me? Can you see that now?
I can see that now, yes.
Perfect. And of course, before I go on, I would like to actually firstly thank Ian, but secondly, congratulate Ian as he's just got his medical retina certificate, and he actually scored 100% in his exam at Moorfields. So well done, Ian. It was nothing to do with the fact that he paid £100 to the examiner. But anyway, we'll carry on. So today's talk is on retinal vein occlusion. You guys see quite a lot of this in the community, especially in Eastbourne, East Sussex, because as you will hear tonight, the condition is much more prevalent as we get older. Something around 5% of patients over 80 have central retinal vein occlusion, and of course, our optometrists in the community are often the first point of call. So before we get on, the mandatory financial interests, previous travel grant, who travels now, from Novartis Bay and Allegan. Email address, if you have any questions, you want to email, you kindly post cases on the East Sussex chat anyway, but if you've got anything you want to ask me personally, feel free to email, website, Twitter and Instagram handles. So the topics covered then, I'm going to talk about different terminology and different types of retinal vein occlusion. What the natural history is, don't forget anti-VEGF has only really been around since 2008 for AMD and 2011 to 12 for CRVO, and BRVO. So actually treatment of vein occlusions included observation. So there's a lot of natural history data that we have. We're going to talk about epidemiology, what you look for, risk factors and causes, what you should include in your history examination, what would be very nice for us to know when you're referring the patient, how we manage it, and what the current service at East Sussex is. So we're going to cover quite a few things. I've also got two videos, which are not mine. I've lifted a couple of nice videos from YouTube, and we would need to take those off the recording when Ian uploads it, because we don't, I don't know if I'm allowed to put that on our kind of video channel, but you will obviously see it on the presentation, but you will see everything else on the video channel when he uploaded minus the videos. So definition then. So retinal vein occlusion is obstruction of the retinal venous system by a thrombus formation. Same as if you have deep venous thrombosis or any other venous obstruction in your body, retinal vein occlusion is kind of a similar process. And there are essentially three main types. So on the left of your screen, as you're looking at it, where my cursor is, that's a central retinal vein occlusion, where the central retina is blocked and you see hemorrhages in all quadrants of the retina. You have hemiretinal vein occlusion, which is probably the rarest form, and that's essentially involving half of your retina. So you would have the nasal and the temporal quadrant superiorly or inferiorly affected within the retina. And you've obviously got branch retinal vein occlusion, which is what you probably see majority of the cases, which only involves one sector. And they can be asymptomatic, especially in branch retinal vein occlusion. If you've got superior retinal vein occlusion, patient may not be aware. So you only tend to develop symptoms if you've got macular edema, or if a large section of the peripheral retina is affected, then they can present with visual field defects as well. So as we mentioned, in a central retinal vein occlusion, the thrombosis is of the central retinal vein at lamina cribrosa. You tend to see a swollen optic disc. Often it's quite difficult to delineate optic disc. You see very tortuous venous system in the eye, and you can also see very deep intraretinal hemorrhages within the eye, and normally hemorrhages are present in all quadrants. In milder form of retinal vein occlusion, you'll see hemorrhages in all quadrants, but the disc may not be swollen, and the hemorrhages will appear less severe. There might not even be macular edema, so you can have very mild vein occlusion. And kind of in a more advanced form of vein occlusion, you might be able to see some disc collateral. So these are kind of when the patient has had vein occlusion and it's all kind of settled down, you might see collaterals forming at the disc. That's a good sign. It means that the vein occlusion is, or the patient is recovering from vein occlusion. It doesn't mean the vision is necessarily going to be good, because that depends on how badly the fovea is damaged. And we'll go through mechanics of that in a minute. But this collateral means that it's a long-standing process and you've got collateral channels that are working now. Sometimes you can see white sheathing around the venous system and of course dilation. So these are kind of the telltale signs somebody may have had a previous vein occlusion. Occasionally I'd see patients where the history is not there for whatever reason. You do an OCT scan, and on the OCT you see very significant thinning in one quadrant of the macula. That's often a sign of a previous arterial or venous occlusion, and the hemorrhages may have resolved, and there might not be any collateral channel. So that's another cue to the chronic forms. In hemiretinal vein occlusion, as mentioned, you can get the superior or inferior part of the hemisphere involved, and you get fairly equal distribution of hemorrhages in the temporal and the nasal side. And for purpose of treatment, we follow the protocol for branch retinal vein occlusion in hemiretinal vein occlusion. I'll come to that in a minute. With a branch, the thrombosis is often at the arteriovenous junction. Very small picture here, but if you look at the back of the eye, you can normally see a crossing between the artery and the vein, and that's often the junction where the venous occlusion occurs. And this is essentially because of atherosclerosis. So as we get older, the arterial system develops plaques in it, and that compresses the vein because they share the same kind of connective tissue sheath. Okay, so I hope that video worked. I was just checking on WhatsApp with Ian, and he said it was working. So that's very important to notice that. So if I just kind of reiterate what the video was showing, was that, as you saw, it's the artery that's the problem within the retinal vein occlusion. And unlike kind of your DVTs and other causes of deep tissue vein occlusions in other parts of your body, the retina is quite different, because the arterial is in very close proximity to the vein. So an arterial disease is the main reason why the vein blocks. Of course, there are other reasons, which we'll come to, but that's the main thing. So getting risk factors for atherosclerosis is very important when you see a patient with vein occlusion. So that's diabetes and hypertension. Those are the big two things that you need to check. And normally you would associate that with strokes and heart attacks, i.e. arterial system, which is the other side, not the venous system. But within the eye, it's different because, as you saw in the video, it's the artery that compresses the vein down. When you get that compression, you get this back pressure. So the mechanics of vision loss is that you have this massive bleed in the retina. The photoreceptors are knocked out of their place. So that's one thing to think about. Two, all these hemorrhages in the macula cause problems because the iron within the hemoglobin is toxic to the photoreceptors. And then the other thing is that don't forget the photoreceptors in the retina receive the blood supply from the layer beneath, from the choroid. So you've got all this hemorrhage and fluid hanging around. It prevents the photoreceptors to get that oxygen. So what they do is that they signal out that they're starved of oxygen by releasing something called VEGF, which you've all heard of, vascular endothelial growth factor. And VEGF is really bad because what it does is it makes the blood vessels leaky, fluid gets more, and then this photoreceptors are more starved of oxygen, and you've got this cycle of VEGF production and more fluid forming in the retina. And the other thing VEGF does is it gets abnormal blood vessels which form from the venous side. And here on this picture, you can see neovascularization occurring on the iris, blocking the trabecular meshwork, causing neovascular glaucoma. You can get fluid, obviously, in the macula from the VEGF production. And that's essentially the reason we use anti-VEGF to block the signal, stop the blood vessels being leaky, so the retina has time to form these collateral channels and get rid of the fluid. So increased retinal capillary pressure, that in itself causes fluid to build up and blood to form, but also the ischemic stimulus from the photoreceptors contributes to formation of fluid in the back of the eye. And central cystoid macular edema is the commonest reason for vision loss in patients with CRVO, which you can see clearly here. And then as kind of the other thing that can happen with vein occlusion, apart from CMO, is you can see here is a retinal fluorescein angiography. If you can see on the top of the picture, maybe it's not showing up very well, the retinal capillary gives you this very nice gray perfusion in the back of the eye. When you've got retinal vein occlusion and those capillaries are all blocked and dead, you can just see this silent almost areas in fluorescein, which is like completely black, and there's no blood flow in that area. And that is why you get all these VEGF hanging around and you get these bright spots at the junction of vascularization and no vascularization, these new vessels. And these new vessels are really bad news because actually they can bleed, and when they bleed, they can cause vitreous hemorrhage. So if you see a patient with central or branches of vein occlusion and have got vitreous hemorrhage, you've got to think that there's new vessels growing there, and we need to laser the patients in order to get rid of these new vessels. Because what you really don't want is this, where the new vascularization process goes up and up and up, and then you get blood vessels on the iris, pressure goes up, and not only they have a blind eye, but they'll have a blind, painful eye. The other problem that happens in neovascular glaucoma is that the cornea then becomes really oedematous, and then you can't laser through the cornea because you can't see the back of the eye. So this is kind of the other reason why patients lose vision. So the three main reasons for vision loss is macular edema, macular ischemia, where you've got basically capillary death around the foveal area, and then vitreous hemorrhage or neovascular glaucoma. So those are the main three kind of things. And then, so one of the things that we would really like to know when you are kind of referring patients is whether you can tell us if this is ischemic or non-ischemic, because that's quite important prognostically. So ischemic just has a much worse prognosis. I mean, essentially, if you follow our patients with ischemic CRVO, many of them have vision worse than 660 after a few years. And we'll come to some stats in a minute. So ischemic vein occlusion is bad news. And the other thing is that approximately, I'd say, a third of patients with retinal vein occlusion are ischemic, 2/3 are non-ischemic, which means the prognosis is better. But a third of those non-ischemic patients eventually become ischemic, and there is nothing you can do to stop that. So we do always mention to patients with non-ischemic RVO, that is all good and they've got good prognosis. Obviously, vision won't be perfect, but there is a 30% chance that the eye can turn and they can lose vision. And anti-VEGF doesn't reverse that. Laser doesn't reverse that. If the eye is going to go ischemic, it's going to go ischemic. So what are the signs that you can look at when you see a patient to see if a patient has ischemic or non-ischemic vein occlusion? Well, the first thing is presenting vision. So if the vision is 660s or worse, that's a sign that the patient has ischemic retinal vein occlusion. It's the same whether it's central or branch retinal vein occlusion. The second sign is presence of relative apparent pupillary defect. So it's very important to check the pupil reflexes when you are examining a patient with retinal vein occlusion, because that can be a very good clue to how much ischemia there is. The third sign is looking at the hemorrhages. So look at the left side of your picture. You can see very deep intraretinal hemorrhage. They just look so hemorrhagic and horrendous looking fundus. But on the right side, you can see that actually you can see most of the fundus. And in fact, you've got a few scattered hemorrhages there. Maybe the top picture here, a bit more hemorrhagic, but you can clearly see the difference between the two. So poor vision, RAPD, deep intraretinal hemorrhages, presence of cotton wool spots. You all know that cotton wool spots is to do with interruption of the flow through the axons, and the presence of that will make you think of ischemia. So you can see 1, 2, 3, 4, 5 cotton wool spots there. So cotton wool spots are important. Very tortuous veins. And then unhelpfully in a clinical setting, one thing that you can do with fluorescein angiography is to look for non-perfusion. This is example of a non-perfusion. So the area on angiogram where you can't see any capillary filling. Now you can't fluorescein this patient because the whole thing is going to be blocked by the hemorrhages. So the fluorescein applies for once the hemorrhages have resolved, and then you fluorescein the patient and you can see actually none of the capillaries are filling. That's what we mean. But that's an angiographic definition. But I'd say poor vision, RAPD, deep intraretinal hemorrhages, cotton wool spots, tortuous veins are all signs that the patient has ischemic vein occlusion and the prognosis is poor. If they don't have any of that, then it's non-ischemic and they have better prognosis, but don't forget 30% will convert to ischemia. With ischemia, they are also therefore at risk of not really responding to anti-VEGF therapy. So you can treat the macular edema, but the vision won't change because damage is done. And also they can get new vessel formation at the disc in the retina. They can then get vitreous hemorrhage. They can get neovascular glaucoma. So with a lot of patients with ischemic retinal vein occlusion, we actually start giving them some prophylactic laser treatment to stop them getting those blood vessels. So I did mention we're going to talk about natural history with central retinal vein occlusion without treatment. There's definitely general decrease in vision. Around 1 in 20 present with vision of 618 to 660. And generally, the vision used to improve with time. Obviously, we don't wait for that now because you can actually treat patients with anti-VEGF therapy. So patients come with macular edema in CRVO, we can actually improve the vision. But if the vision is going to improve on its own, it generally doesn't improve beyond 612. So the rule of thumb is if you see a CRVO, they've got macular edema, you treat with anti-VEGF. In the old days, or back in, before 2012 or 2011, we didn't have anti-VEGF, so there was no other choice but to wait. Macular laser for cystoid macular edema in CRVO does not work, and it wasn't recommended. So all you could do is to wait and see whether they get better or not. But check this out, more than 90% of patients with ischemic central retinal vein occlusion have vision of 660 or worse. So it is bad news if you've got ischemic CRVO. Normally, in a kind of hospital setting, we follow patients up for about 2 years. And if they've not had any intervention or they've not required any intervention, we can discharge them back to the community. But if they're having anti-VEGF therapy, laser treatment, they've developed neovascular glaucoma, all those things, obviously we carry on observing at hospital eye service. Branch retinal vein occlusion, better prognosis than CRVO. It's much better to have BRVO than CRVO. And look, 50 to 60% of patients have vision better than 612 at 1 year. And although the nice kind of guidance tends to say that if the vision is worse than 612, consider treatment. But my thinking that if we can actually treat on the NHS with anti-VEGF therapy if they have symptoms. So you don't have to have a vision threshold, unlike wet AMD. With RVO, with a central BRVO, if there is vision that's affected, we will treat with anti-VEGF if there is macular edema. And 20 to 40% improve vision on their own, but again, it doesn't tend to improve beyond 6 to 12. And don't forget, 5% of patients with central or branch retinal vein occlusion can have bilateral disease. So the natural history is not great, better for BRVO than CRVO. Generally, vision tends to go down with time. Small cases, you can get kind of spontaneous vision improvement, but often the vision doesn't improve beyond 6 to 12. So as a rule of thumb, you see CRVO, BRVO, refer it in. We normally want to see these patients within a month. For wet AMD, it's 2 weeks. For RVO, we try to see within a month. Good for you to please put in what the vision is, if there's any RAPD, if you see any other signs of ischemia that may worry you, or definitely if you see any new vessels. Intraocular pressure is very important in patients when we are triaging your referrals. And then we try and inject patients with anti-VEGF if they have macular edema within the first month in order to try and improve their vision. If there's no macular edema, there's no point in doing anti-VEGF. So anti-VEGF is only useful if there's macular edema. So as far as epidemiology is concerned, it's the second commonest cause of vascular blindness, second to diabetes. And you tend to see 500 new cases of, there's actually, interestingly, no data in the UK, which is astonishing. But there's around 500 new cases of CRVO and 1,800 BRVO per 100,000 patients or population in the US. And the incidence massively increases with age. As I mentioned, less than 1% under 60 to over 5%, well, nearly 5% in over 80s. And it doesn't really, there's no gender or racial difference in this. And as I said, to get 5%. Majority causes of vision loss is due to macular edema. So etiology, we had a bit of a discussion. And if you remember the video, just think about what can cause arterial disease, which can then pinch the vein as it's crossing it. So we look for hypertension, diabetes, hyperlipidemia. That's quite important in a young patient, in particular if they have familial disorders which can affect the lipid profile. So high cholesterol and high triglyceride can cause vein occlusion. So that's important. Those top three are the main three things really. In a young patient, so if you've got somebody who's less than 50, raised levels of homocysteine has been shown to be something that we need to look for. And then you get to the more unusual things. So this is very important to ask about other medical history, because like the other venous systems in your body, any coagulation disorders that can make you prone to venous occlusion can cause RVO, like myeloma or Waldenstrom's macroglobulinemia. So those are important things to ask for. But normally, patients with those conditions tend to have been diagnosed with it, and it's unlikely that the eye is the first manifestation of blood disorders, because they would normally present with anemia, bleeding, and other stuff. Systemic inflammatory conditions also important. If you imagine, we've got Virchow's triad here, which is generally used for thrombosis. If you've got compression, hypercoagulability, or vessel wall injury, these things can cause thrombosis. So if you've got anything that makes the venous blood vessel walls sticky, it can cause clotting. So we're talking about sarcoidosis, we're talking about SLE, all these kind of inflammatory conditions can cause venous occlusion. Glaucoma has been touted as one, but normally high pressures, so I'd say pressure of more than 30, 35, that can cause occlusion of the venous side, especially if there is some arterial disease as well. Shorter axial length, because everything's probably crowded, and of course, external compression. So top three are the main three. Homocysteine is more in kind of much younger patients, unusual disorders, and then always do ask about other inflammatory or blood coagulation disorders in order to try and get to the cause of it. And with respect to risk of rubiosis, the highest risk is in ischemic central retinal vein occlusion, and then hemiretinal vein, and then branch retinal vein occlusion, which kind of makes sense. Although interestingly, the new vessel disc risk is higher in hemiretinal than central retinal vein occlusion. I'm not sure why that is. But generally, if you've got ischemia, you're at high risk of developing these abnormal blood vessels, which is not good news. So in this picture, for example, you will see lots and lots of multiple hemorrhages. So that is a sign that this patient could have ischemia. So special circumstances, I would say that at least 20% of patients develop poor visual outcome with severe neovascular disease, but that kind of goes without saying. Causation of retinal vein occlusion in younger patient is unclear in most cases. Although we do actually see, so younger patient does present a dilemma, we do throw the book at them, I must say. Dehydration is meant to be something you ask for. So I've seen this in few very young marathon runners who have done the marathon and then developed the retinal vein occlusion, severe diarrheal disease, which is called massive dehydration. If they've been out on a big night out and had one too many pints and not had a big drink before they go to bed of water, and then they can wake up with one of these. So dehydration is important, but if you've got a young patient who clearly isn't diabetic or has hypertension, you do want to check about all those unusual things. So anyone who is under 50, or if they've got bilateral disease, I will then look quite significantly at all the other unusual blood disorders and things, which I'll come to in a minute. So generally, when I see a patient in an eye clinic, there are only a few things that we need to check within the eye clinic. So obviously within the history, you check if they have hypertension or diabetes. Often I will ask the GP to do a 24-hour blood pressure. One-off blood pressure I feel is not really sufficient in most cases because it probably doesn't tell you very much about what the blood pressure is like. So we do normally ask for a 24-hour blood pressure. The only circumstance you probably don't do that is they've already got hypertension. So you'd write to the GP and say, look, is the blood pressure controlled? But if they are not hypertensive, we'll ask for a 24-hour blood pressure. We will also ask for HbA1c to check if they're not diabetic. So we've checked blood pressure, diabetes, and the only blood count that we tend to do in a routine central branch hemiretinal vein occlusion who is expected within the age group would be full blood count and ESR. I mentioned that obviously you ask medical history is very important to ask for any other thing that you think might contribute. But then you write a letter to the GP and say, could they basically look out for risks of atherosclerosis? So we don't do any blood coagulation studies or anything else in clinic if the vein occlusion is typical. But if it's atypical, i.e. if it's in both eyes, which is unusual, or if the patient is less than 50, then as I said, you do need to throw the book at them. So I do look at the coagulation, kind of various coagulation disorders. So factor V Leiden, antiphospholipid antibody syndromes, protein CNS deficiency. Now these patients may have other issues. So if they are young females, they may have had recurrent miscarriages. If they may have had PE, DVT, all these other things. So it's important to ask about that in a young person. And apart from kind of the history, blood pressure, diabetes, full blood count and ESR, with a full lipid profile, we check for inflammatory disorders. So ANA is kind of your generic test for inflammatory disorders. And if that's positive, then you need to look further in. But that's kind of your general check. We check for syphilis and lupus, as well as serum aspartate. So there is more extensive investigations if the patient is atypical, i.e. bilateral or less than 50. But if they are kind of your typical RVO type patient, then blood pressure, diabetes, full blood count and ESR is all you need. And the reason you do full blood count and ESR is because that is kind of your general screen for myeloma or something like that you don't want to miss. So is there any inflammation going on? Is there any anemia that could explain blood coagulation disorders? If that's normal, then that's it. You don't need to do anything else. And then you concentrate on treating the condition. So when a retinal vein occlusion patient comes, first thing is, can I avoid, why did it happen? We need to avoid it happening in the other eye. And then the second thing is, let's treat the eye in order to improve the vision. Now, investigation-wise, in clinic, obviously an OCT, which almost all of you have now, so it's a very typical cystoid macular edema pattern that you see in retinal vein occlusion. we have had this wonderful OCT angiography in clinic now for some time, and it's quite useful when you don't want to do fluorescein angiography. So this is dye-less. There's no dye injected in this patient. OCTA works with two different, what you call them now. They track the blood cells, basically, red blood cells in the blood vessel, and they delineate the blood cells. It's a very, very clever system. And it basically tells you where all the capillaries are. So here you can see a patient with a fairly normal capillary, and here you can see a very extended foveolar vascular zone, and here you can see loads of capillary non-perfusion. So these patients are very ischemic and will have poor vision. So that's OCTA. You don't have to have OCTA. You can do your typical fluorescein angiography, and that will show you where there are areas of non-perfusion. It will also show you if you've got abnormal blood vessels. So if you've got new vessels, you know it's ischemic, you know they're going to bleed, it's going to run into problems. So you need to laser the retina in order to get rid of the ischemic process. And the reason laser works is because the laser kills off the photoreceptors. And the photoreceptors are the things that release VEGF. So you stop the cycle there. Anti-VEGF does exactly the same thing, but we use anti-VEGF mainly for treatment of macular edema. You can't use it to treat the new vessels because NICE hasn't approved that. But as a byproduct of treating macular edema, it also stops developing the new vessels, which is quite good. So remember, macular edema is the commonest cause of vision loss in central branch hemorrhagic vein occlusion. But the other reason for vision loss is, of course, if the macula is ischemic, like here, like ischemic macula, okay? Or if you get these abnormal blood vessels, you get vitreous hemorrhage or neovascular glaucoma, corneal edema, etc. So macular edema and neovascular disease are the two reasons. Okay, so that basically told you how pan-retinal photocoagulation works, which is to get rid of the VEGF. So all you're doing at this time is getting rid of this horrid VEGF, which is driving everything and making everything worse. As I said, from the initial insult of the photoreceptors, from the vein occlusion, if the photoreceptors are damaged badly from the physical trauma of back pressure when the vein blocks, there's nothing you can do about that. The only thing you can do with when there's, or if there's ischemia, i.e. capillary loss around the fovea, again, there's nothing you can do about that. You can't make the capillaries grow back. The only thing you can do is to get rid of the macular edema and restore retinal anatomy by making the photoreceptors not so stretched and they go back to the original shape, and hopefully they will start working. So if I have a patient with macular edema and I treat, the retina then goes flat after 3 injections, but the vision is 660, there's not much point in carrying on because anti-VEGF is not going to help that patient anymore. The damage is done. So it's important to understand that anti-VEGF and PRP, but anti-VEGF for macular edema does not reverse or does not regenerate photoreceptors. It just normalizes the anatomy of the macula. If the photoreceptors are damaged because of iron toxicity, because of pressure, trauma, of all these things, then unfortunately there's very little you can do, which is why it's so important to have the initial vision, to know whether there's any RAPD, to know whether there's any deep intraretinal hemorrhages, because those are telltale signs that things may not be better or may not get better. So management then, so you've all heard of Lucentis and Eylea for AMD mainly, but we use the same anti-VEGF therapy for macular edema affecting all sorts of vein occlusion. Unlike diabetic macular edema or wet AMD, NICE did not thankfully stipulate a vision or criteria for treatment. As long as the patient was symptomatic, we could go ahead and treat. And of course, I tend to use anti-VEGF therapy in almost most patients actually, but mainly you target it towards those who are phakic, and if there's no cardiovascular risk factors or if they have glaucoma. And the reason for that, now I'm saying that, is because we have another treatment called Ozurdex, which some of you may have heard of. This is a steroid pellet, 700 mcg, which is released over 4 to 6 months. So you release the pellet, basically releases 30 to 4 mcg of dexamethasone in the vitreous, which then helps the macular edema. It works very well. However, the main problem with Ozurdex is that, one, they will see a floater in the eye because that's the pellet that moves around, especially if you've got quite a fluid vitreous, it moves around quite a bit. But also it can cause an increase in eye pressure, and in a small group of patients, it can cause glaucoma which may need trabeculectomy or pressure lowering treatment. And then, so apart from the pressure problem, it can also cause a cataract. So generally, patients with 1 or 2 Ozurdex will develop a cataract. So although, again, in retinal vein occlusion, you can use Ozurdex, Lucentis, or Eylea in any patients with central hemiretinal branches of vein occlusion, you're probably better off using Ozurdex for those who are pseudophakic, so they're not going to get a cataract, so you don't then have to do cataract surgery, or if they've got lots and lots of heart attacks or strokes in the past, because there's that theoretical risk with the anti-VEGF in that age group. So steroids would be quite used for that. It would be quite good for that. Don't forget, the pellet is less than 1 milligram. So you're inserting a very small amount of steroid into the eye. And Ozurdex is also used for treatment of macular edema for uveitis, non-infectious uveitis as well. So it's quite a good treatment for that. And then conversely, use the anti-VEGF for those who obviously have glaucoma. So there is pressurized when you put anti-VEGF in glaucoma patients, but it's not sustained, and the pressure comes down. It's more of a mechanical thing than anything else. And of course, and it doesn't induce a cataract. So that's kind of how we try and manage it. But one of the other things, oh, sorry, that's not what I wanted to do. One of the other things we do is that the nice thing about Ozurdex is that the patients, in theory, need only 2 implants in a year. So in a patient who responds very well, you could just get away with 2 implants and 4 visits in a year. So if you've got somebody who's very elderly, has had cataract surgery, is perfect. Or if somebody who just doesn't want to come to the hospital quite a lot, Ozurdex would be quite a good option to use. Anti-VEGF, as you know, is used between 4 to every 6 weeks. They need to be seen and perhaps treated. So the treatment is a lot more labor intensive with anti-VEGF compared to Ozurdex. But having said that, I would, in my experience, I think patients normally need 3 Ozurdex in a year rather than 2. Oh, and in a very small proportion of patients with branch, not with central, you can treat macular edema with laser treatment as well. Although it would not be my first protocol, and I rarely use laser for macular edema now. It is mainly anti-VEGF therapy. And then if they've got new vessel disease, then you laser the retina very strongly to stop the formation of new vessels, or if they're formed so that they regress. So that's panretinal laser. I've written Avastin here because if you remember, I said if you get neovascular glaucoma, cornea can get quite oedematous. Well, if you give intravitreal Avastin, then the new vessels on the iris can regress, and you then have a very short space of time where the edema can clear. You obviously have to give them IOP lowering drops and tablets, and then you can laser the retina, and that will that's one way of managing the neovascular glaucoma. And if they're unlucky enough to develop vitreous hemorrhage, then they need vitrectomy. But you would be hard pressed convincing a VR surgeon to go in if the patient had very ischemic CRVR and they're not going to have much functional vision. So it's really better to kind of try and manage the situation here rather than allowing it to develop. So how do we manage the loading dose? Well, if it's anti-VEGF, 1 a month for the first 3 months, then we see them every 6 weeks. And at the moment in the trust, we have a 2-stop process. So they have the first, second, and the third. And then after that, they're seen every 6 weeks. They have a scan and a vision. And then if they need treatment, they're called back for an injection. And then every year, we would then have a face-to-face 2 or 3 times a year. So they're probably seen 10 times to 11 times a year. Most of those will be virtual visits with injections indicated if they need it. Out of that 10, 11 visits, 2 or 3 are face-to-face because the OCT won't pick up new vessels. So during the face-to-face, you look for new vessels of the disc, iris, and the back of the eye. And the Ozurdex, you give the initial implant, then you do pressure, OCT, vision at 2 months, and then you do a face-to-face 2-3 months later to see whether they need another Ozurdex. You can actually mix and match, so you don't have to use this or the other, especially with Ozurdex. I've got some patients who've got very aggressive disease, so Ozurdex may stop working after 2 months or 3 months. although you can repeat Ozurdex at 4 months, that's off-label. Normally, you should only do it twice a year. But if you are going to do it sooner than 4 months, then you would probably use what we call a rescue anti-VEGF. So you give them Lucentis or Eylea and then do the Ozurdex at 4 months. Normally, patients can need 2 to 3 implants a year, which can be quite useful if they don't want to come to the hospital frequently. Cost-wise, but these are costly. So, Lucentis and Eylea can cost anywhere between £550 to £816. That's just the injection cost per vial. So they're very expensive treatments. And if you think if a patient needs about 10 of those, just the injection cost itself is about £10,000. And then you've got the injection cost itself, which is about £60, the hospital visit, £100. So an anti-VEGF using Eylea or Lucentis can set you back about £10,000, which is quite a lot. In England, we can't use Avastin for patients who have NICE approved treatment. If we could use Avastin, then it would be a lot cheaper. If you're a patient in America or most of Europe, they probably start with Avastin first and then only switch to Lucentis or Eylea if that doesn't work. But the regulation is different here, and that would be a lecture in itself. So I'm not going to get into that. But anyway, that's how that works. And Ozurdex is about £870 per implant. Now, I don't know what the NHS prices are. It's probably a bit cheaper, with what the NHS negotiates, but those are kind of outside my my remit, I'm afraid. So lots and lots of clinical trials have been done. I've mentioned this because when you look at clinical trials, Allergan, who produced the Ozurdex, are not very good at trials because they only look at Ozurdex twice in a year. But actually, if you compare your pseudophakic patients and you look at vision with Ozurdex maybe 3 times rather than twice in a year, it doesn't compare too differently to anti-VEGF therapy, and potentially it's a more cost-effective way of doing things. But as I said, my general view is that if they've glaucoma and are phakic, I tend to use anti-VEGF, and if they're pseudophakic and they have had lots of cardiovascular disorders, I tend to go for Ozurdex. Or if they really don't want to come on that often, then probably Ozurdex. So what about 5-year outcomes with retinal vein occlusion? Well, this kind of shows you a very nice picture over 5 years of changes in visual acuity, which you can see you can gain up to 10 to 15 letters of vision, even ischemic ones. So ischemic vein occlusion doesn't mean you can't treat them, it just means the prognosis is more limited. But generally, there is, over 5 years, the vision can significantly improve, and you can see changes in central cell thickness, reduction of 200 to 300 microns of fluid there. With branch retinal vein occlusion, probably more sustained and better vision gain with anti-VEGF therapy, and similar reduction in retinal thickness. With vein occlusion over 5 years, again, got to be a little bit careful interpreting these. So, generally you can see up to 30 injections, but trials generally tend to have very strict injection criteria. So I'm often very, very careful when I'm talking to patients about how many injections they may need, because if you're kind of saying what happens in a trial, it might not happen in real life. And in a trial setting, generally, the treatment is given very, very aggressively in order to make sure that you're showing that the treatment works. So the retreatment criteria is generally quite aggressive. But normally, I would say, your CRVO patients need a lot more treatment than your BRVO patient. And the first couple of years, you might need anything between 3 to 12, 13 injections, but really after your third and fourth year, it tends to come down. As I said, unlike DMO and wet AMD, NICE doesn't have any restrictions with who you can treat. So any patient with macular edema with those kind of conditions can be treated. And then I've got some local data from our trust where we looked at Ozurdex. It's actually quite a good thing to write up as a paper because there are not many I've not been able to find anything in the trial setting to have followed up patients for nearly 3 years. But we have quite a good cohort. Just need to convince one of my juniors to write this up. But essentially, we had out of our group of patients, so we had 77 eyes of 76 patients, which were followed up for nearly, up to 42 months, range of 35 to 65 months. And a quarter of them had their Ozurdex within the first 3 months of macular edema. 92% were phakic. So most of our patients were phakic with Ozurdex. This is purely looking at Ozurdex, not looking at your Lucentis and Eylea patients. So this is pure Ozurdex patients. And majority were kind of treatment naive. Few had received previous laser and few had received anti-VEGF. But look, overall, over the kind of that period of time, which is what we've average of 42 months, they only needed 3 implants over that time, which is actually not a huge amount. So that's why I'm saying you've got to be careful comparing your kind of what happens day to day in a clinical setting to a trial setting. And of course, these patients go up, look online and see that you need 30 injections over 5 years and freak out. But actually in real life, you might not need that many, and each person is very different. I always think trials pick patients who are most likely to show improvement in vision. So they often pick on moderate to severe disease. So those kind of patients will end up having a lot of treatment. But if you catch a patient early and treat them early, then you can sort them out. So the biggest thing with treatment and prognosis is what vision they start out with, whether they're ischemic or not. And if you can start the treatment within 3 months, they will have a good outcome, as long as they don't become ischemic. So for ASH, for anyone with RVO as an urgent, useful to have obviously vision in the referral. If you can do a scan of OCT, or if not, if you write what the central retinal thickness is, would be great. Mention if there's RAPD, mention if you see if there are any new vessels, that'd be really good. Any important medical conditions would be greatly appreciated, so diabetes or hypertension, or if they've been diagnosed with any weird hematological disorders. And we really aim to see these patients within 2 weeks or 3 weeks, and certainly start treatment within a month. That's our kind of usual thing. And that's why we have got plenty of injection sessions where these patients can get slotted and go in and have treatment. And yeah, when we see them in clinic, we have a chat whether they want to do anti-VEGF or Ozurdex. You can start on either. As I mentioned some of my preferences and why, but in some patients, it might be that they want to turn up less, and that's what you would do. Right, I'm done now. Thank you for staying awake or listening. Ian, where are you? Hello?
Hi, Shah, can you hear me?
I can hear you now.
I'm just come back online now. Thank you very much. That was really, really interesting. That was. I think I've got a couple of questions, but there's one question I was going to ask, and I got a bit distracted because trying to help somebody get online. But I think you mentioned early on in your talk about the difference between CRVO and BRVO. So if in community we see these, did you say there was different urgency of referral for BRVO or CRVO? Or?
No, I think as soon as you pick them up, you send them in ASAP. There's definitely no doubt. Because essentially one of the things you want to make sure is that this is not going to happen in the other arm. So, and I think at that point it's important for us, once we receive the referral and confirm the diagnosis, we want to check the patient's not diabetic, they don't have hypertension. Most of them would have the history of it, and they're just not controlled. Sometimes you do pick up a new diabetic or somebody who is hypertensive. So, and then with treatment, criteria for treatment would be macular edema. So if they've got macular edema and the vision and they have symptoms, then we treat. We don't, because if you leave it, the natural history is that in the small proportion that get better, the vision is often not better than 6/12. So there's no point in waiting if they've got macular edema. And I think, it's very rare for a patient not to take it on. I do occasionally see patients with macular edema, but the fovea is not involved. So you see a hemorrhage coming right down to the fovea. Vision is 6/6. They're not really aware of much. In those circumstances, you might want to wait, but I would maybe see them with a virtual scan 2 or 4 weeks to see if there's any change.
Yeah.
If you pick it up, send it in as an urgent.
Cool, thank you. So going to the questions then. So thinking of eye pressure as a cause of CRVO, what level of IOP would they likely occur?
Yeah, I think normally 35 and above. Obviously, that's kind of correcting for the corneal thickness and etc. So, so if you think about your ocular hypertension patients, once the pressure starts going over 30, you start thinking about definite treatment. So I would say 35 and above, I'd be worried. But in a very compromised system, i.e., if you've got an old patient who's got really bad atherosclerotic disease and the vein is kind of really kind of already compressed, you might want to think about starting it sooner. But yeah, I would say 35 and above would be, yeah.
Thank you. So can you use Avastin instead of Lucentis and Eylea?
Unfortunately not, because, so this is kind of the big talk. So basically in UK, if you have a product that's licensed by NICE, okay, then you have to use that. I.e., NICE says, right, central vein occlusion, branches of vein occlusion, if they've got macular edema, you can treat. And these are your three options, Ozurdex, Lucentis, Eylea. Therefore, you cannot deny a patient those licensed products because there's a cheaper alternative around. The only time you could do that if your cheaper alternative was superior to their products, which it's not. I mean, Avastin is as good as, but it's not superior to those things. Now, if you have a patient, say, with wet AMD or diabetic macular edema, which fall outside of NICE, because NICE doesn't provide treatment for them, and if there is no local commissioning agreement to treat those kind of patients, then they are stuck a little bit, because these patients can't have NHS treatment, but a group of them would benefit from treatment. And in that circumstance, then you can use Avastin. At the moment in this area, it's private. Some other areas, if they've got that commissioning agreement, then you are able to bypass it and go. It all depends on what it is locally. But yes, I agree. In an ideal world, what we should be able to do, what we should do is to give everybody Avastin within the NHS, because we'll save loads of money. And then if they're not responding to Avastin, then try the high cost drug. But it's just, unfortunately, a bit crazy that you are kind of in certain, not in RVO, but in certain other conditions, you have to ration the treatment until the condition is a bit more advanced, but then they will only have access to the more expensive drug. But this argument has been going on for years. There's been various lobbying going on. And basically what it comes down to is for the group of patients who are outside NICE treatment, if the local commissioners don't have an agreement, you can't treat them. But the answer is yes. You can. Avastin is as good as the others for conditions, and you can interchangeably use them. So there are often patients who don't respond to Lucentis, we change to Eylea, they don't respond to that, we change to Ozurdex, and vice versa.
Thank you very much for that. So why is checking for RIPD important?
Because if there is RAPD, then that means there is significant damage to the retina. And that is one of the things that we look for in ischemic vein occlusion. And if they have got ischemic vein occlusion, then the prognosis is very poor. Remember, in ischemic CRVO, 90% have vision of 660 or worse. And what's often sad, I had a couple of patients who blamed anti-VEGF for it. They started off with vision of 612, 618. They had a couple of anti-VEGF injections. Vision crashed to counting fingers. And what had happened is they've gone from non-ischemic to ischemic. Nothing to do with the anti-VEGF. It's just natural history. 30% will do that. And of course, they thought, oh, it's the anti-VEGF. And unfortunately, in that group of patients, there's very little you can do. So it's important to be able to subgroup them. Is it ischemic? Is it non-ischemic? And in the non-ischemic, I always warn them that there's a 30% chance that they may do badly, irrespective of anti-VEGF therapy. All anti-VEGF does is treat the macular edema, return the macular anatomy.
So roughly what percentage occur bilaterally?
5%.
5%. Thank you. And in your experience, how many patients ever complained of defective night vision post PRP?
I think that's a very good question. I think it depends on how much you do. So if it's in one eye, then it doesn't tend to be too bad unless you're closing one eye and checking with the other. If it's bilateral and you've treated both eyes, then, of course, don't forget that's something that they need to inform DVLA about. You generally have to have treated quite a bit of the retina for them to be aware. I mean, I've seen patients with quite good going PRP scars who still pass their estimate visual field test. But we are a lot more careful now with laser treatment, especially a lot of these vein occlusion patients would have had anti-VEGF for macular edema, which would have treated some of the neovascular disease. So we don't maybe laser them as heavily as before. But if you see some of the pre-anti-VEGF laser treatment patients, you can't see any of the peripheral retina. And those patients have very bad tunnel vision and they definitely can't drive. So, as long as it's in one eye, you're probably okay. If you're unlucky enough to have had ischemic vein occlusion in both eyes, heavy laser both eyes, then it's quite common in that scenario. But that's rare.
Yeah. I'm going to jump around questions. I think you've already answered this one, but is Avastin comparable in effectiveness with Lucentis and Eylea?
I think, yeah. I mean, I think, generally, if you look at vision as a primary outcome measure, then it compares favorably to them. It's not better, which is why we can't use it on top. So if you think about some of the chemotherapy drugs or cancer drugs, or in fact, a lot of drugs used in pediatrics, if you've got an off-license product where the manufacturer hasn't applied for licensing, you can argue using that over licensed products if there is trials to show it's better. If it's not better, you have to use the licensed product. So if you look at vision as primary outcome, then it's comparable. But maybe if you look at 2 or 3 years, number of injections, you may need more injections with the Avastin when compared to Eylea, for example. Not so much Lucentis with Eylea. So that's kind of a secondary outcome measure. But, Avastin is about 40 quid.
Yeah.
Manufacturing, maybe 60 quid. Lucentis and Eylea are, between 600 to 800 pounds. So, as I said, we are bound by this red tape, unfortunately, which is a problem. But there's legal ramifications around that, and so that's the whole different talk together. But yeah, the answer is yes.
So moving on quickly then, with increased waiting times, e.g., urgent referrals taking 12 weeks, would it be acceptable to send patients to A&E if the only way to get them to see within a few weeks?
I mean, I think if you've got I'm assuming you're talking about, so if you've got a vein occlusion patient, I would imagine, you'd know this better than me, Ian, that you can directly refer that patient to the eye casualty inbox. And within that, you need to write clearly, it's a vein occlusion, central or branch. Please write the vision down because that helps me triage. And if you can't stick a scan image on it, then write the central retinal thickness. So on your OCT, you've got 3 circles, write down the value in the middle circle, the innermost circle. And that will tell me about the vision, the CRT, and then any other features like hemorrhages, RAPD, all that would be important. You put that in through the casualty inbox, we will see that patient within a week.
Yeah.
Because we've got PCC clinics running all the time.
I think if I was, this was within our area, I would refer that via the direct to the our website for the East Sussex sort of ophthalmology urgent department, really, rather than A&E.
I wouldn't use A&E, and I wouldn't go through the GP either. These patients, anyone with urgent ophthalmic, so I'm talking about retina now. So wet AMD and retinal vein occlusion, okay, just within the realm of retina, these do not go towards GP because that just delays the process, or to A&E. Just email the casualty email that's looked at every day, printed, a consultant triages it, and we will see that patient within a week.
Yeah. Thank you very much. I think the next question is for me, actually. Will a recording of this session be available? It will be available, and it will be on our YouTube channel, the East Sussex Eye Group, and I will put that up soon. My wife will help me to put that up soon, as Shah is laughing in the corner. So a recording will be available, but it might have the videos cropped out, as Mr. Kashani said earlier in his.
Yeah, so obviously one of them was American Academy, and the other one I can't remember. I mean, there were kind of the references there, but we probably ought to crop those videos out. I mean, you can get them online anyway. If you go on YouTube and put in CRVO, you know, they're educational stuff.
But there will be a recording of this lecture. Next question. Do we also need to refer a patient to a GP or stroke clinic for urgent systemic investigations, or is it done at the hospital?
No, we will be doing that. So I think the first thing we would do is that we confirm the diagnosis, and then we will do the panel that I mentioned. If it's typical RVO or if it's atypical, we will organize that locally. But then, so most of the patients are going to be typical, because atypical is bilateral or less than 50, okay? So most of your patients are not going to be in that group. So if they are in the older age group, you just do full blood count, ESR, I'll write to the GP about 24-hour blood pressure and HbA1c for diabetes. And then within it, we will also write, please check for risk factors of atherosclerosis, and then they will do the rest. As I think I would leave that to us, because we're going to see the patient within a week and we will deal with it. So you don't need to write that separate. That's vein occlusion. Branch retinal artery occlusion, again, is urgent. That needs to be seen that day, unlike a vein occlusion, because in arterial occlusion, then that's a stroke, isn't it? That's stroke affecting the eye. Yeah. So that patient gets seen there and then. And again, that comes through the emergency casualty inbox, but that has completely separate features.
Cool, thank you very much. I'm jumping between questions and chat here. And back in chat, are occlusions in young type 1 diabetics common?
No. So generally, I think with vein occlusion, if you're under 60, the incidence is generally quite low, less than 1%. Obviously, if you're very poorly controlled type 1, have got hypertension, high lipid, then the risk goes up. But it's still quite unusual to see a young patient with retinal vein occlusion. I'm not saying it's not possible, but I don't see that many. I mean, I would say, you know, the patients that come through, maybe I see 10 in a year, somebody who's quite young. And although the hydration thing is a bit controversial, I do often ask about it.
Cool, thank you very much. The other questions are relating to CET points, so not from Mr. Kashani, but to answer hopefully all of the questions that have been asked, I will, if you've applied for this webinar with the link I sent you, then you put your GOC number on, you've logged on, I will upload your CET points. You don't need to do anything as long as you've been logged on for at least 90% of our webinar. So 50 minutes, if you've logged on, I will upload your CET points. You don't need to do anything, I will do it all. How would you get CET points? I will put it on for you as long as you've logged on. What's the urgency of established retinal artery occlusion?
That day.
Question.
That day. So if you've got an arterial occlusion, you need to make sure the patient is not at risk of a stroke. So we would want to check their ECG, make sure they're not in fast atrial fibrillation. We need to make sure that, so they're going through the stroke team. And if you've got a retinal arterial occlusion, again, you go through casualty, and we see the patient that day. We do ESR and CRP to make sure it's not GCA, giant arteritis. Okay, so ECG, full blood, you know, and they have the whole panel done that day. So that's a lot more urgent. And with those patients, we also send them to the stroke team, and then the TIA team see them within 2 weeks. They do all sorts of echo and ECG, echo and the cardiac. Now, echo and carotid Dopplers and things like that, and MRI scan actually, to look for things, or is it CT? I don't know. But those things are done within 2 weeks. But when they come to us on the day, we will do an ECG to make sure that they're not in fast AF. We will check ESR and CRP to make sure they don't have GCA.
Cool. Thank you very much. I think there's a couple more questions, but I think it's Mr Kashani has got his wife's birthday and he needs to be spending time with his family. For all those who asked, I will upload the CET. I have 7 days to upload the CET with the GOC, so I will upload that this weekend. And I hope you'll watch our next webinar, and I will post that. But I would like to say a very special thank you to Mr Kashani for tonight, especially for his webinar. That was a really, really, really useful webinar. I often half watch them, but tonight I thought that was. Thank you very much.
Look, that's why you got 100% in your exam, Ian. I mean,
well, it says
we have a picture of you in the eye clinic, I think. Anyway,
so thank you very much, all. I will upload the CT and I'll put the YouTube video on next week. But thank you very much.
Don't forget to get rid of the videos.
I will press end now.
Thank you. Bye.
Thank you. Bye-bye, all.
Bye.